Welcome to the Sustainable Clinical Medicine podcast. I am your host, Sarah Smith. I am a practicing rural family physician and the charting coach. This is the podcast for physicians and advanced practice providers who are ready to step back from the busyness of their clinical day to share ideas, question everything, and redesign their clinical day. We are redesigning clinical medicine to create sustainable clinical days and create time for our lives outside of medicine. Join us for discussions with world experts who are helping design sustainable models of clinical medicine and the physicians or clinicians who have discovered or designed sustainable models of clinical medicine for themselves. Hello and welcome back, everybody. Before we get started, I just wanted to remind those of you who are working on backlogs, just check in the www.chartingcoach.ca/backlog-buddies is a place you can come and do your backlog alongside fellow clinicians and physicians. So if you want to kind of hang out and have some ability to stay on task for the 2-hour sessions, come along. We'd love to see you there. Now, for our guest today, we have Dr. Chandi Chandrasena. Thank you so much for joining us today, family medicine physician, similar to what I practice, but you're going to hear all about Dr. Chandi's life and all the things she's doing to help physicians in Ontario. So welcome.
Thank you. I'm so honored to be here. It's so great to chat with you.
Thank you. So tell us about you and your journey through medicine and what ended you up in family med. I know you're no pressure, just
I feel like as I age, that journey just gets longer and longer. Um, I think a lot of us go into family medicine for the same altruistic reasons. We just really enjoy working with people and we just want to make a difference. We just want to be in a job where we help people. And I think that's like every med student's like essay as to why they want to be a doctor. I started. I'm dating myself here. I was meds 2000. So I started about 23 years ago. So med school, just like everyone else does. So I did med school at University of Ottawa. And then I did my residency up north. So at that time, it was called NOFM, the Northern Ontario Family Medicine Residency. And it was before the Northern Ontario medical schools had opened. So I think we might have been the last cohort of residents who were there without the med students. At the time, my plan was to be a rural northern doc and kind of journey through that because I just found family medicine's like one of those amazing specialties where you can do anything with it. And you can work in so many different areas and you can just kind of, fix it, like make it kind of fit into your life. And so I really liked rural medicine. But unfortunately or fortunately, my husband is not a physician. And I think he just found it really hard to find work up there. So we moved back to Ottawa, and that's where I've pretty much been since then, actually, with the odd locums and kind of jaunts out. So comprehensive family medicine, right? Your cradle to grave family medicine, kind of working full time, various different clinics. I think everyone has that journey where they start off as a locum, maybe, then a walk in, and then a clinic, and then their own clinic, perhaps. So that's been my journey until more recently, as you alluded to, where I'm the chief medical officer for Ontario MD.
Yeah. Actually, the leaving residency and doing locuming is interestingly not the process that most physicians in Australia would kind of do. This was new to me when I came to Canada, that the residents finish up, become certified, and then go off on locum for a while. And I'm like, why would you do that? I mean, family medicine's hard enough, let alone not having that support of your supervisors continuing on in a. So my personal journey was I finished my compulsory supervised family medicine years within our training program. And then I got interviewed by all of the practices in the area to kind of showed me what was on the cards, where I could go and practice. And then I chose which one I chose for the reasons I chose it and started work there. So this whole locuming thing was very interesting. Tell me about that as a brand new grad going
Yeah.
and locuming. What's that like?
It's scary because you're kind
Yeah.
of on your own. You're walking into this new environment. You don't really
Yes.
know what's happening, and then you're thrown into it.
Mm-hmm.
So I have to say, if I had to locum now, I'm not as flexible as when I was younger. But what was amazing is I did rural family medicine. And so with rural family medicine, you did everything.
Mm-hmm.
So you would be a hospitalist, you'd be in the emerge, you would be the family doc, you would kind of do a lot of things. So I think that gave me, in retrospect, because at the time I didn't have any confidence, but in retrospect, I can see that it really did give me kind of that flexibility and that confidence to be able to handle anything.
Mm-hmm.
But so I really liked it. So I had a mentor at that time who basically said, don't settle down. Once
Mm-hmm.
you settle down and you start your practice, it's really hard to leave. Kind of like your EMR, you're kind of handcuffed to it, right? So what they said is, you know what? Figure out where you want to be. Figure out what type of practice you want to be. Build a practice slowly. Don't just jump into it. So I think I got a lot of great advice.
Mm-hmm.
And unfortunately, I also graduated with a giant loan. So I had to pay that off. And locuming was very lucrative. You would get to travel because I would locum in the north. So they would pay for me to go to all these cool places in Northern Ontario. They'd put me in this really nice cottage, usually on the water because they want me to stay. They're
Mm-hmm.
super nice to me. Everyone's super friendly. And then I would make like X amount of dollars a day with no overhead. And that
Mm-hmm.
would be what I earned. And it was really easy, right? And so I was able to kind of just do 2 weeks of intensive locuming, and then take it easy for a week and then do it again. And it was a great way to pay off loans at that time
Mm-hmm.
and get your feet wet and then figure out where you want it to be. And that's kind of the advice that I do still give residents, is don't jump into something, right? Especially now. It's more like you can choose where you want to settle, right? Like it's kind of like you're in control where you can decide, is this the clinic you want to spend time with? Do you like the way they run? Are you happy with the technology? Like I think that same advice would hold now.
Yeah. What about, were you the only doctor in the area? Were you soloing, or were you in amongst a team, but that one person that you're locuming for is out? Like, what
Yeah.
did you have any rules around that for yourself?
Well, so I didn't have any rules because I was just like desperate to work, right? I should have had rules. So I sometimes I would be alone, and it would be terrifying. So I have to say, I have really good network and good friends. So
Mm-hmm.
and I think a rural residency really bonds you more because all of you are kind of thrown into these small areas and it's sink or swim. So when we graduated, we made this pact that whatever locums we did, if we were up at night, the other people would be available for them like through the night if you needed to text or call or figure it out.
Mm-hmm.
And I think sometimes just knowing that if I got over my head, I could like text someone who's going to pick up the phone at 3 in the morning and help me out.
Mm-hmm.
There was a bit of a kind of a camaraderie ship there, right? But it varied. A lot of times I was alone. There would only be like one doc who was in that little town, and then they would leave, and I would be it. Um, in retrospect, I feel like I would have much better advice for my past me because that was not smart.
Yeah, I was locuming in areas in Australia, but this was 7 years post grad with 2 years of critical care training under my belt before I went to family med, because part of our rural family med was you did your hospital terms and then you went out and did your uh, general practice terms. So I had 5 years of full-time
Wow.
general practice under my belt and 2 years of critical care training before I went locuming into these places where I was 400 kilometers from the nearest other physician. And even then I would question why I was there. But the interesting thing, I think what you're alluding to is as a rural grad, so as a rural physician, you are given responsibility a lot earlier. You
Yeah.
are part of the decision-making team much earlier. You're pulled up through the ranks and given the the first hand at the patient. If things have to be done, you're the one doing them, but you're in a very well supported, protected, with your supervisors looking over your shoulder or hand over hand, kind of helping you do your first ever
Yeah.
chest tube or, whatever. It gives you that clinical courage, perhaps, maybe that's what you're alluding to about the rural training. And we certainly see that within our ICC longitudinal students in community here, is they are working as junior residents within their final months of their third year medical school here in community, because they are part of the team. Like we are like, hey, you are here to learn. Let's help you learn and let's bring you up through the ranks. Yes.
Yes. And you know what else? Again, it's a generalization, obviously, but I find in general there's a teamwork in rural areas, right? Like everybody is there. So they might not be another physician, but there's easily this amazing, knowledgeable nurse who's also there to kind of make sure that you're okay. So I kind of feel there's people supporting you.
Mm-hmm.
And at the time, like the community also, like they realize there's only one doctor and I'm new. So there's a bit of a forgiveness also, like, maybe they were nicer to me. I'm sure I made tons of mistakes. I'm sure the doc came back and went, "Oh my gosh, who is this person?"
Mm-hmm.
Um, but overall, I found that that was really good. And it's true what you're saying about that team of where you learn, because when I'm up north at that time, there was no medical students. So it was just you and your attending. And so basically it was a very one-to-one. So you learned a lot. What I
Mm-hmm.
didn't learn was how to work with other people and manage the med students, but I totally learned medicine because it's very different when you come to like I'm in Ottawa. So when I would do an elective in the urban center, I'd just be like, why is there all these people? How come I'm not the one who's learning this? Why do I have it's a little different.
Yeah, no, it is for sure. What did you find that you were struggling with as you went out into the world on your own? You didn't have your usual community, but you had them on the phone.
Yeah.
What did you find about those, like the workload, the managing
Yeah.
patients, the getting through the day, the finishing the day? How'd it
It
go?
was hard. You know what? I think in the beginning, I kind of feel like it's been a huge blur. So I don't actually remember as much. Like you ever have that thought that you're just like kind of stuck in what's happening now, that you
Yeah.
don't remember what it was like before? Um, it's hard because I think we're not taught to be time managers or manage our patients or manage our charts. Like it's not a skill that we graduate from med school with. And I think it's a huge gap. Like I really do think we're not taught the business of running a practice, especially for family docs. I feel like that is like probably the biggest gap that I see, other than digital health, which is the other
Mhm.
gap that I see. Um, so I think so when I came back to Ottawa, back then, we weren't on EMRs, right? Like these were paper charts. So you'd walk into a clinic and there's like that sea of charts and that file folders, and you're kind of dependent on the staff to bring you the right chart and that stuff. You're assuming stuff has been filed in because you can never know if it has or not. So I think when I was more urban, it was kind of nice because there's always other docs around. So you
Mhm.
build that network. So you're kind of like, okay, I could easily talk to someone. And there was this, again, camaraderie ship. Like the older ones knew that the younger ones are going to come and ask questions. And I don't think any time did anyone tell me I'm too busy to talk to you about this, right?
Mhm.
Because they would ask me questions too, because I think it's
Mhm.
a bit of a give and take.
Mhm.
Um, and I was very slow in the beginning. I'm still slow. Who am I kidding? I chat too much. Like this is why I'm late all the time. But I think life seemed to be easier in terms of being a family doc, I would say 20 years ago or even 15 years ago. It didn't seem to be as chaotic and hectic. It was still busy. Like, don't get me
Mhm.
wrong. It wasn't like a walk in the park, but I feel like I don't know what it is, life, maybe it's our technology, maybe it's like what our regulators expect us to know, patient expectations. It's probably all of it. But I just kind of feel it's just a lot more now than I felt back then.
Interesting. Tell us about your day now then when you're seeing patients. How that all kind of melded? Because you then obviously transitioned through to an EMR.
Yeah.
Yeah, tell us
Yeah.
about that.
I transitioned in 2010 to an
Hmm.
EMR. So I'd already done about 8 years of family practice. And so what I started off, I did locums in the initially. And then when I came back to Ottawa, um, another piece of really good advice from a mentor was don't just take on your practice. Like then there's no capitation, it was just fee for service, right?
Hmm.
So what they said was don't just go and take over a practice. Like there's plenty of patients. Build it slowly, train your patients as you go along, set up your protocols, set up your policies, figure out a clinic, and then go into it a little bit aware of what you're doing. And I thought that was excellent advice because I would work in walk-ins. And then in the walk-ins, there would be all these patients that didn't have family doctors. And they would ask me, and I would say, okay, this month I'm going to take 10. So then what I would do is I was primarily a walk-in doc, but I would slowly build this practice on the side. And at that time, you're young, you've got all this energy, you're not jaded yet. So my thing was, okay, I'll just take everyone over the age of 70. So it's kind of like anyone who's over the age of 70, if they don't have a family doctor, I'm going to totally do this because I feel like they need to have a family doctor, right? So then I slowly kind of built my practice. And then as we went on, I would take like families. And it was very much whoever asked me would basically be on my roster. But I build it very slowly because I wasn't depending on my family practice to be my income because I was still the walk-in doc, right? I was still kind of
Hmm.
seeing patients and paying my bills. And I found that to be really good. And policies, right? Like, so I had, so another thing is I had this package that I had patients fill out back then, right? It would ask them their name, it would ask them their past medical history, their blood, like their medications, what they're worried about, list all their problems. And it was like 3, 4 pages. And the first page would be rules. Like, it would just be like, this is the way I run my practice, right? I'm not available on the weekends. I'm not available in the evenings. So this is fee for service in the beginning. It's a lot different now, but I set my boundaries. I was like, if you miss an appointment, this is how much it's going to be. This is how, and it was a piece of paper, and I made them sign it on the first appointment. I would have an appointment meeting with them, and I would say, hey, this is the way my practice runs. If you're okay with it, you're happy with it. Like, I'd be like, don't yell at my staff. Don't, I don't give a lot of narcotics. As long as you're okay with this, sign here and I'll take you on. And I found at that time when I had time to kind of train and manage expectations, it was a lot better because when people push back, I'm still a pushover. Like it's easy for me to say this, but when people push back, I could always say, "But you knew this signed on. Like you knew this was the way I ran my practice, and you were happy with." So I found that was actually kind of nice. And so wherever I went, I would slowly build this practice until I think so 2 babies in between there, so a couple of mat leaves, and then in 2010, I opened a practice with 3 other physicians, thinking, okay, this is going to be our practice. We're going to do all the things that other clinics didn't have.
Hmm.
And that's when we transitioned, or I did. Some were already on EMR, but that's when I transitioned from paper to EMR.
Hmm. Yeah. The time to set up those boundaries and rules with your practice, and of course, you have had the autonomy to do that. Not all physicians or clinicians have that ability to say, here are the rules that we abide by. How did you handle those 4 pages, for instance, of information? Like, was that something
Yeah.
that you would then sit and read? When would you do that? Those
So
kind of things.
they had to fill it out before they saw me. This is the way it was, right? And so it was kind of like that would be the starting point for the first appointment. And I have to say I continued this throughout. Like I know it's a bit labor intensive, but I always found that if I took the time in the beginning and put that effort in, it made it a lot easier. So the first appointment would always be what I would call a meet and greet. And so I would sit with them and then we would go through those pages, right? So I would say, okay, it says here, you've got diabetes. Tell me about that. Or it says that, I'll go through the family history. And then before it was just paper. So I'd be writing in my
Mhm.
CPP, when you glued it to
Mhm.
the front of the chart, and I would just be writing it there. And then I would write, okay, when was your last PAP, your last mammogram, and that kind of stuff in the chart. And then as we went to EMR, that's where I would enter it. So as they're talking or later, I would enter all that information into like it was basically my CPP and my history taking. So that's
Mhm.
what that became. And I know some of you are probably like, who has time for that? Like, honestly, I feel like you need to invest in your flow. And so to me, that investment of spending that time, setting those expectations, and really getting to know my patient in that first visit where I gave them that time actually paid off later. So when they came, I already kind of had a really good background on them. And we'd already established that rapport because I had patients who would be like, oh, you're not the doc for me. Like, they would push back and I would set my boundaries on the first meeting and they'd be like, oh, you're not the right one. And then they wouldn't come back. And I'd be, okay, that's great because obviously it was not a good fit. And that probably would have caused problems later. So this is when there was other docs that they could see. So granted, it's a little different now, but back then they could pick and choose a little bit, right?
Mm-hmm. Yeah, yeah. All right. So the EMR, you said you were part of the initiation of that. How did that go with your flow with your patients, do you
Oh
think?
my gosh. So it was helpful that two of the docs were already on it. So they were kind of using it. But switching from paper to EMR, oh, what a nightmare. Because you've got your charts and then you're seeing this patient and who has time? Like I can't type all this in, right? So I
Mm-hmm.
would literally have all these charts. And then by then I had a full practice, right? Like full, like probably around 1,200 kind of people. So as I would sit down, I would have this paper chart and then I would just kind of add in, and there was a lot of after hours for that. And then at one point, I think I might have hired someone to kind of go through the charts and just put in the last 5 years, like the
Mm-hmm.
PAPs, the mammogram, like the stuff that you need to know.
Mm-hmm.
But it was a huge transition. And then at one point within that first year, I hired a company who would take the charts, make them into PDFs, and then I could attach it to the EMR, or it would be on a separate, like a password protected icon on your desktop. So
Mm-hmm.
then if I had to go to the EMR, I could find your chart, see the PDF, scroll through, and then I would enter it into the EMR, right? And I found that actually worked the best for me. So that way I didn't have to keep the paper charts because they'd been scanned.
Mm-hmm.
Um, and then I was able to always have access to it. But after a couple of years, I realized I never looked at the old charts, right? Like
Mm-hmm.
then your EMR becomes your chart.
Yeah. Okay. So that delegation, you had learned that early.
Yes, delegation.
So tell us about the Ontario MD, because that's an interesting organization that's helping physicians with the flow of their day. Tell us about that.
Yeah. So, Ontario MD is a subsidiary of the OMA, the Ontario Medical Association, which is our PTMA. And so at the time, 2004-ish, is when there was this push to get physicians on EMRs. And so at the time, the government was funding for that to happen. And so they had to find a way to funnel that funding to physicians. And
Hmm.
so Ontario MD was created at that time for that purpose of managing the funding, but also the change management, because we realized you can't just give any technology and say, hey, here's an EMR, like go forth and prosper. Like
Hmm.
there's teaching involved. There's like looking at your workflow. There's this huge change management piece that has to be done. Otherwise, you're not going to be using it properly and you're probably going to burn out within a couple of weeks of using it, right? When you can't even turn it on. That's pretty much how this started was like, how do we do this change management? And so this was before I had joined
Hmm.
OMD. So this is how they had started. Um, and they had this brilliant strategy for change management, and they had developed advisors. So, what the advisory staff or an advisory service, who were staff that were trained on onboarding, change management, understanding physicians' workflow. A lot of them were previous office managers or previous office staff, and they really understood how community physicians work. So it's community specialists and community family docs that was targeted. Um, and they lived where they lived. So it was like Ontario MDs in Toronto, but
Hmm.
this field team, they lived throughout the province. So they lived where you lived. So if you were at a local meeting for, let's say, the hospital, they were probably there also. And they really understood kind of what happened in like in the local area as well as the provincial, which is a bit brilliant, I have to say. Because honestly, I am no longer a rural doc. But
Mm-hmm.
when I was a rural doc, I wouldn't want someone from Toronto to come and tell me what to do. Like it just would not work, right? But hearing it from someone rurally actually just makes more sense because they get it, right? And then the other part of the program was a peer leader program, which was also a really amazing part. And the peer leaders are consultants, so they're not staff. They're usually physicians, but we have nurse practitioners, office managers, and nurses. And what that is that peer-to-peer piece. So let's say you onboarded to your EMR, your vendor has given you the training, you're kind of like, yeah, I think I got it. Then it's just not working. There's like glitches, you don't really know where to go. Then you would call OMD and they would come, they would send a staff and possibly a peer leader, and you would kind of get that art of the possible. Like this is the way
Mm-hmm.
we're super users, so this is the way we use it, right? And
Mm-hmm.
then it kind of inspires you, like, okay, this is doable. And then we're there to also help your staff with those changes. So it's that whole piece where it's not just about your EMR or your technology now, because most people are on
Mm-hmm.
EMR. So now we've pivoted to just workflow technology and everything else that's out there that's kind of tech related. It's not, you need to have a change management piece around anything, like forget tech, anything. And you need it to stick and you need the changes to be tweaked. Like it's like a PDSA cycle if you're doing QI. But it's kind of the same thing with like an approach on technology, which I thought really made sense at that time. And
Yeah.
so that's the way it started.
And what is it doing now? So what are the things that physicians within your sphere kind of working on at the moment? So because change is constantly happening. We're still
Yeah.
having updates coming in. They've got new places where information's kept, like lab results and provincial housing of information.
Yeah.
And integrating that into your EMR so you don't have these siloed work lists. Like what are you seeing now? What are physicians needing help with on a day-to-day now, do you think?
So you know what? I think the issue with so it's a technology lens that I'm talking about, right? So
Mhm.
there's a lot of burden that's been created,
Mm,
and it's been created for a number of reasons, right? So I think I kind of alluded to it earlier. I think some of it is just that the data can come through into our EMR now. It's amazing. Like when I was in paper, if a patient went to the emerge, they would come back with this envelope when they saw me, and there would be like 3 sheets in there folded, which would be the discharge summary. And that's really all I needed to know, honestly, right? Maybe there
mhm,
was a CT scan in there. Um, but now it all comes directly into my EMR, and that 3 page discharge summary, no word of a lie, it's about 15 pages now, right? And
mhm,
everything's been pulled in because it's like super easy to be in a hospital and just click, click, click and keep adding stuff. Um, and then that all gets sent, right? And so there's like this burden of paperwork where now we're kind of obligated to read every line because somewhere in there might be a nugget where which tells me what I have to do that if I don't do, it's going to be horrible.
mhm,
Um, so I think part of technology is that we didn't understand the inadvertent consequences of the ease of sending all this useless data to us, right? And that's just kind of expanded forms, different portals. So the other thing is, I always say, what is it? Hindsight is 2020. So now I can look back and say, oh, how come when they had these EMRs, why didn't we talk about coding and data entry into right data fields? And why didn't we force interoperability and integration? Like we could have done this in the beginning. But
mhm,
it's easy to say now because we see the problems, but at the time it was a new technology and nobody wanted to go on it. So could you
mm,
imagine if you're a doc and I come in and I'm like, here's this EMR, which you don't want to go on to anyways because you're happy with paper. And then I tell you, okay, you have to change, you have to code things and you have to like enter things properly. So you can't just
mhm,
free text it. And we're not going to give you any money for that extra time. Like you're just going to retrain. Like, yeah, no one's going to sign up, right? So I think Yeah, so that's created a lot of burden, right? So
Hmm.
we do spend a lot of time working on that interoperability piece. Like, how can we integrate this in? Is there like a hack in quotes that we could do so that it's a bit more seamless for you? How do we get rid of all these reports coming in? How do we kind of get these forms populated so you don't have to do it?
Hmm.
Um, so I think that's the biggest part that like that's the biggest part of my day is kind of looking at how do we decrease that burden and how do we prevent that from happening with the new stuff that's coming down the pipeline.
It's nice to know that there's somebody in there having our backs or trying to have our backs in terms of, hey, we're bringing in this new system, but it will integrate with your current system
I
really
know.
well. I mean, that just takes that whole, oh, thank you.
But I don't think people understand how complicated our health system is, right? Like you would think that would be such an easy ask, right? Like whatever you develop should just integrate. But
Hmm.
if you think about it, like BC has 30 different EMRs. So
Hmm.
and so it would be really like hard to integrate with all 30 of them if they don't even integrate between each other, right? Like Ontario has 12, I think 12 or 13. And then other provinces have more. And so it's very hard to get a technology that's going to integrate with all of them. And then also, I think sometimes I go, if I was a vendor and I was developing something and people were going to buy it, whether it was integrated or not, like, well, why would I kind of have you trapped. So why would I improve it, right? I'm probably gonna get fired for that comment, but it's kind of like, why, like, what's in it for me, right? To improve this. So I think that's part of what we have to navigate there for sure.
Yeah. So EMRs might have initially been an idea because now things are legible
Yes,
and searchable,
yes,
but we didn't count on the complexity of now I've got to wade through 15 pages to understand why you were in hospital and what I have to
yeah,
do next. And in order to create that referral or figure out when your last pap smear was, I got to go searching through
yeah,
15 different parts of my EMR to maybe find it. Um,
yeah.
yeah, you're right. It did add a lot of that administrative work back to the expert in the room
Yes.
who's trying
And
to
then,
help coordinate your medical pieces.
well, this is it, right? And I think what it also did is it took that, it made me a very highly paid admin is what it did, right? Because all of a sudden, what my front staff was doing was directly sent to me now. Or the portal had to be done by a physician because only physicians are allowed on, say, these portals, right? For privacy reasons or whatever. Then consent came in. And then all the privacy legislation around our EMRs and how we run our offices. And like now it's just complicated, right? Because in the past, I just had charts that you probably couldn't read. And if you wanted them, feel free. You're not going to understand them anyways, right? And there was no consent at that time. I didn't have to say, you understand, I'm not going to share your data because nobody wanted it. No one could read it anyways. But I think it's not just the EMR. I think it's just the whole process of what we're going to. It's just so complicated now, right? And it's something as simple as like the reports we get from the hospital. So, Ontario, because of the burden of reports that were coming in through our technology platform, which is called HRM, which is, I have to say, it's a brilliant technology in the sense
Mhm.
is it replaced the fax. Like you just seamlessly got it, like email in your Hotmail account, right? Whereas before it was mailed and scanned in, or you had to search for it. Now it just came in. And you're like, how easy is that? But you just didn't count it on being like 50 pages, right?
Mhm.
Um, so now we have a task force to look at that burden to say, okay, we need some rules and recommendations and regulations or ideas as to what you can actually send us. And we need to bring in all these stakeholders like the hospitals, like the government, CPSO. Like, are we really responsible for all 50 pages? Like, is that reasonable to put that on us right now? Like, is it still the same responsibilities that we had before, right? Like, even the impression, like now it's kind of buried in places. Like, can we not just move that to the front? So you just tell me what you want me to know in the first like half page, and then I can read the rest if I feel like it.
Hmm.
But this is what I'm responsible for. Like, can we not make it a little bit easier? But that takes a lot of effort and advocacy to even change stuff like that. But that's what we're trying to do with our task force recommendations.
Mm. Okay, so that's part of, is that Ontario MD's part of
That's
the
Ontario.
task force then?
Yeah, yeah. So
Yeah.
we led the task force, and we have recommendations. They were published. And so now it's just a matter of, okay, can we get these onboarded and adopted and the change? And what does that look like?
Hmm.
Um, but I think it's important to note that even though HRM is an Ontario platform, it's not the platform, it's more the reports coming through. And that's a problem across all the provinces, right? So it's almost like what we've developed also are standards as to what you should be sending through anything to an EMR. Like you're not going to mail someone this. So if you're not going to mail it to them, why would you think it's okay to fax it to them or send it through an EMR, right? Like it's just kind of like a standard for what's acceptable.
Hmm. Yeah. What are some of the fun things that have come out in the last year or two that are helping reduce the burden? What do you think that looks like?
Okay, so I think I'm like one of those nerds who get really excited about technology. So I don't think anyone else is going to think this is fun. But I'm really looking forward to AI.
Hmm.
So AI has really taken off. So I'm really looking forward to seeing the functionality. How can we identify gaps and where can we go with it?
Hmm.
With the caveat that I think we also need to step back before we adopt and look at it and kind of look at the contracts we're expected to sign. Look at the fine print, the liability. There's a lot there where you have to be careful. And then look at like a framework of evaluation. Like, how do you know which one is right for you? How do you know which one is going to work for you? And kind of see if there's a way you could identify the gaps, the biases, and understand what those are. And then could we somehow push the way AI is, right? Like, so could we actually dictate how AI is going to fill those gaps that we need? So in the future, in 5 years, I'm not going to be like, oh, AI is ruining my life. Like, I wish we had more control over it.
Hmm.
But so I am pretty excited about AI, but I
Hmm.
think we still need to look at it carefully and methodically and kind of make sure that we look at those unforeseen burdens, as I usually say.
Hmm. Yeah, yeah. I think prescribing has kind of changed in the last year. What do you
Yeah.
think?
Yeah, I think I think it's that integration piece. As physicians, I don't think we can deny the importance of sharing data, and the importance of kind of having that data follow patients as they go through their journey so that other physicians, like a hospitalist or ER doc or whoever, or even other healthcare members like home care, should have access to some of that, right? So that interoperability piece. And prescribing is part of it. So every province kind of does it differently.
Hmm.
And I think that's what happens when healthcare is provincial, is
Hmm.
that everyone kind of does it differently, and then you're kind of looking for something that helps kind of nationally. And so there's a number of modules in our EMRs. So in Ontario right now, we're prescribing independently. So primary care prescriptions don't go into a repository of sorts yet. Right now, there is what's called DHDR, Digital Health Drug Repository, which holds all narcotics that are prescribed in the
Hmm.
province by anyone. So that's a great thing.
Hmm.
It holds anything that's prescribed by a pharmacist, or any
Hmm.
vaccine that's given by a pharmacist is there.
Hmm.
Any ODB. So if you're over 65 or under, was it 25? I think you're on ODB by OHIP. Those medications are put into there. And anything for anyone that's on social assistance on ODB, that goes into there. What it's missing is like my prescriptions in my office for a patient that doesn't fit into one of those criteria. And that's a good
So
bulk of
then when you're referring to the cardiologist or whatever, you have to actually list what meds you've got them on, hoping no
exactly.
other family doctors also having their say in
That's
it.
it.
Ridiculous.
I
What?
know. I know.
Oh my
And I
goodness.
feel so bad for my specialist colleagues who are like, this is what your family doctor says. And then the patient's like, I'm not taking any of those. Like,
Yeah, and then you even try ringing the pharmacist saying, okay, what have you got them on? But then they couldn't get into
yeah,
their pharmacist on Saturday, so they went down to the local blah blah
this
that's
is
open
it.
on Saturday.
And
Oh my goodness. Yes,
yes,
that is quite the
yeah,
challenge. And I
that
think it's
is.
not, you're not alone when you're saying that that is something that needs fixing. I think for sure one of the things I've seen come through in the last year is um uh at least a function where I can prescribe in my office and it gets directly deposited into their physician, sorry, into their pharmacy's database ready for dispensing. That is saving me so much time in the room. And that technology is Canada wide, which I love.
Yes,
Um,
yes,
so good. And any EMR, like it's completely free for me to use and it integrates with my EMR. I'm like,
yes,
yes, please. Let's have more of these things come out.
yes,
Um, Most
yes.
definitely.
And so and I think we're talking about the same technology. So there's various adoption in each province, right? So some
Mhm.
provinces have adopted it. I think Alberta has, if I'm not mistaken, whereas other provinces are still trying to figure out where it fits in or the adoption's not there. But you're right, like when I said pharmacy prescriptions go into our database, it's pharmacy prescriptions that they prescribe, not
Yes.
any, right? And you're just like, how is it that all of this doesn't just go into this database? Like it doesn't make sense to me
Yeah.
why it's not there, right?
Yeah.
And
No, Alberta does have all of except the new hospital system did not decide to bring across that technology. So if you're in the hospital system now, the doctor has to go back to the provincial system to find the actual med list you're on, not, and we integrated this when we brought it into the province for you. No, we did not. So we have this hospital doctors can't necessarily see what you're on unless they go into the provincial system to find it and bring it into the hospital system and type in each thing separately. I'm like, oh my
oh my
goodness,
God,
because we
oh my
just
God.
had that arrive in our hospital here. I'm like, oh, this is so much fun. I can find your drug list, but it's not in your computer system. Now I have to add it one by one. Um,
That
Delightful.
is horrible. But that's a perfect example of how we
Yes,
operate in silos.
perfect
Like
example
it's a
of
perfect
let's make the
example.
doctors do more work. So
Yes,
it's that
yes.
additional 10 minutes when I'm seeing a patient
Oh my
is
God.
just the data entry of your medications, which exists in this list, but not in your new EMR in the hospital. Love it. Yes.
This is why we're all burnt out, I think.
It contributes. It does
Yes.
contribute to why we have some of the access problems is I
Yeah.
can do what I can do and I can't go any faster. And there's a wait list. Yep,
Yeah.
there is.
Yeah.
Because I can't go any faster and I refuse to do it tonight.
Yes.
So it's being done right now. And yes, anyway.
Yes.
Okay.
I
Dr.
agree.
Jenny, how can people find or look into what's available if they are in Ontario or they want to kind of check out what Ontario MD is offering to them to help them with their workflows and improving
Yeah.
systems in their practice and their clinical day to make things a little more efficient for the things that are possible right now, knowing that you
Yeah.
have their back in developing
Yes.
other good things? Yes. Where do they find you?
You know what? It's interesting because I do think burnout and administrative burden and what's happening, this is a health system problem, right?
Yeah,
Like this
of course
isn't
it
a
is.
me problem or a clinic
Not
problem
a
or
me
you're not.
problem.
This is like a health system problem. But you're absolutely right. There's stuff you can do in your
Yes.
clinic to create
Yes.
that capacity, right?
Yes.
And so if you're in Ontario and you're a physician, you are part of the OMA. Uh,
Mhm.
Automatically. And so you have access to our services complimentary. It's free of charge. So we don't charge for any of this to happen. And so you would go to our website, OntarioMD.ca. I'm gonna double check that and put that in the I should know this off heart. And it's clearly marked there like do you want a peer leader? Do you want an advisory service? It's written there. We're in the process of upgrading our EMR, our portal, our web page, so that it'll be easier to search. But when you
Mhm.
go in there, you'll be able to find that information. Um, and then you can also email me directly. So I'll give you the email address for that too. I'll quickly look at that while we're chatting later.
Mhm.
And if you send an email to that, we can get you hooked up with these services too. So what we do is we've got our advisory service, like I said, we have our peer leader service. We
Mhm.
also offer like a robust digital health service. So we've got webinars at lunch times that are recorded and on the web page. We have a conference, a digital health conference, which is like the only digital health conference for primary care in all of Ontario. And I don't know if there is one nationally, but it's well received, and you can learn a lot of tips and tricks and ideas about how to find time and gain a little bit of capacity there.
Mhm.
And then we also have our digital e-tips, which is like an email that comes in once a month to you, which also has tips and tricks. So
Mm.
we're really about that practical part, right? Like, what can you do now? And here's one thing you can tweak to do it.
Mhm.
If you've been tapped on the shoulder for a QI CPSO project, because every 5 years we have to do that,
Yeah.
you can use your technology, and finding time as one of your projects. So we can help you with that also.
Mhm.
So there's kind of a number of places that we can kind of help. And then we can also get you, like, the main thing we do is onboard you to all the digital tools that the province has and what's coming down the pipeline. So we can get that put into your EMR also.
Yeah. So if there is things that are helping this all flow more seamlessly or be more
Yes.
efficient, or there's faster prescribing options,
Yeah. We
this is
can
where you'll
help.
find it. You will
Yeah.
find all of those because Chandy keeps right on top of it with all of her team, right? Anything that can
Yeah,
save you
right.
time. And I think that's the bottom line here is we're always looking for that. How can I make this even more sustainable,
Yes.
easier, less burdensome, so I can get back to looking after the patients and trying to do my part in the
Yes.
patient care piece. Yeah, so good. Thank
Yeah.
you so
Yeah.
much for your time. Is there anything we didn't cover that you wanted to say while we're here?
Yeah, you know what? I think the other important part is setting boundaries with your technology. And we don't always talk about that, right? We don't
Mhm.
always talk about digital wellness. So I have these like 5 Bs, and I'll tell you like super quickly. Like, the first one is set your boundaries and guidelines. So when you're using technology with patients, set the expectations. So if you're using secure messaging or you're emailing, like, write what you're going to do and what you're not going to do, and be
Mm.
very blunt about it. Because if you set those boundaries, and your staff should know it, it really helps, right? Bucket filling is my second B, is that you need to find something to fill your bucket, right? So if it's building relationships, and see if you could use technology to spend more time with your patients building relationships. If it's something else, use technology to find you time to do that. But you have to kind of find something that fills your bucket at work also, so
Mhm.
that you still want to go to work, right? Breaks. None of us take lunch or take breaks, right? Like, I think everyone's like, yeah, I don't remember the last time I had a lunch. But I would say you need to schedule breaks away from your technology. So you could still be working if you don't want to take a break, but you just need to step away from your EMR. Like, if you're at home, I usually say open the door, take a breath of fresh air, and then go back to your virtual visits or something. But you got to take breaks. And then building capacity, to me, that's about training. So
Mhm.
it's like, learn to use your technology properly. Because
Mm.
most of us do not know the functionality of our technology that we have. And if we can start using it properly, we can actually create some of that capacity and become more efficient. And then the last one is balance, right? So it's
Mhm.
like that work-life balance. So set realistic expectations of what you're going to do in the office, and do it as a group. So if you've got like 5 docs, take a lunch and learn, and talk about what your rules around technology is going to be. Like, how often are you going to check labs? Like, I wouldn't check them all the time, but that's what we do. Like, set a
Mm.
time for it. If you're on vacation, be on vacation. Like,
Mm.
come up with, like, don't look at your labs when you're on vacation. Super easy to say, but you're not on vacation if you're looking at labs, right? So those are my 5 Bs: boundaries, bucket filling, breaks, building capacity, and balance. So I kind of,
Yes.
because we talk about tech, but we don't talk about the rules around tech, and that's
Yeah.
important.
Yeah, I mean, you are 24/7 available. Your inbox is filling up 24/7, just like your laundry basket, like we talk about,
Yes.
that it's always there. And so it's you who has to turn off.
Yes. You are in control of, I mean, it's so easy for me to say, but I'm you. Like, that's what I had to do, and
Mhm.
didn't. So then you start getting burnt out and not happy and just need a
Mhm.
change, right?
Yeah.
But yeah, you need to do this.
Yeah, absolutely. We want to look after you too. Yes. Love it. Thank you so much for this
Thank
conversation.
you.
Have a wonderful rest of your week and happy holiday season to you
Happy
all.
holidays too. And thank you so much for having me.
My pleasure. Thank you for being part of the Sustainable Clinical Medicine podcast. If you'd like to learn more or join us to help you get home with today's work done, go to chartingcoach.ca. There you'll find all the information on the premier Lifetime Access Charting Champions program that is helping physicians get home with today's work done, with all the proven tools, support, and community you need to create time for your life outside of medicine. We would love to see you there. Until next time, thanks for listening.